Good morning, everybody, and thank you for joining us at 11:30. I hope you're taking this opportunity to have some lunch. The goal of this CME and CEU time was really to make it sort of a lunch and learn. Kind of a weird way to do it, but this is kind of how the times are. The topic today for this CME/CEU is electronic convulsive therapy, breaking the stigma of ECT. My name is Gavi Berman. I'm the Director of Business Development for Central Florida Behavioral Hospital. I'm joined by our sister hospital, Fort Lauderdale Behavioral Health Center, and the Director of Business Development down there, Kimberly Leon, who's on here as well. And we're going to be your hosts for today's webinar education. So before we get started, just a couple of housekeeping items. Today's webinar workshop is 1.5 hours long. That's including Q&A, which will be at the end of the presentation when the presenter opens it up. All participants are going to be muted during the webinar. We have too many people on the line, so opening up the phone line would be very difficult. So I'm going to encourage everybody to use the chat function or the Q&A function. If you have any questions during the webinar, we're going to monitor all questions throughout the webinar, and we'll answer as many as possible toward the end. So any questions, please go ahead and just throw them into the chat box and hit send. Also, this webinar is being recorded, and it will be made available on the resource center of our website, Central Florida Behavioral Hospital, and Fort Lauderdale Behavioral Health Center will have it available as well. So if you didn't have the opportunity to join us live, or those of you that know others that might be interested, you can absolutely share this with them and use it in the future as well. That should be up on our website within the next week or so. When the presentation ends, and this is important, when the presentation ends or you exit Zoom, you're going to automatically receive your web browser. It's automatically going to take you to the survey that has to be completed, the evaluation, in order for you to get the CME and CEU credit for those of you who are eligible. So make sure it's, when you see that alert, don't be alarmed. It looks kind of like a salesy alert or something you'd automatically want to close out, but follow it. It's going to bring you automatically to the survey when you close your browser or you leave Zoom or I end the meeting. All attendees today that are eligible will receive 1.5 CME credits or CEUs. You should have given me your license number when you registered. There was a place for you to do that. So if you haven't done it, feel free to, I'm going to send an email following this webinar to everybody with the certificates of completion. So you can absolutely email me back if maybe you didn't give me your license or you just want to make sure that you gave me the correct license. But I do have your licenses when you register, and we'll go ahead and make sure that those are processed in CE Broker, whatever platform they use that for the CMEs, to have credits within the next 30 days. And with that, we're going to go ahead and introduce the presenters. Kimberly, are you there? Do you want to introduce Dr. Gaines?
Yes, hi, good morning. My name is Kimberly Leon. I'm the Director of Business Development at Fort Lauderdale Behavioral Health Center. And I'd like to introduce our Chief Medical Officer, Dr. Jared Gaines. He is a native South Floridian born at Broward General Hospital. He completed his undergraduate and medical training from the University of Florida. Dr. Gaines is board certified in general psychiatry and completed a fellowship in child and adolescent psychiatry at UF, as well as a fellowship in ECT at Emory University. He was also recently certified in TMS in 2019. Dr. Gaines served previously as the medical director for Orange Park Medical Center in Jacksonville, medical director for West Palm Hospital, and is now the chief medical officer at Fort Lauderdale Behavioral Health Center.
Thank you, thank you. And I'm absolutely delighted to present to you guys Lois Tanio. She is our program manager here at Central Florida Behavioral Hospital. And we're also, I want to mention, super excited to be partnering with our sister hospital, Fort Lauderdale Behavioral Health Center down in Fort Lauderdale, to be able to provide this type of training. I think it's a training that we don't see too often. ECT is kind of a little bit of there's absolutely a stigma to it, which is why we're doing this. And I think just having the opportunity to really broaden our audience between the two hospitals and the geography is just a tremendous opportunity. And we're super excited to have Dr. Gaines with us. Elodie has been with our hospital since 2008, since we opened up, and she started and manages our ECT program. Elodia is one of the most passionate and caring people that I've met personally. ECT is not something that's easy to talk about. It's not something that's easy to do. You need a compassionate person. If there's one person that I can say, I'm just, so happy to be able to work with and to be able to talk about in the community about who manages our program, it's Elodia. She has the experience, as you can see here, and she's just been doing it for a really long time. And with that, I'm gonna go ahead and hand the microphone over to Elodia to kick off the presentation.
Hello, everybody, and Gavi, thanks for that gracious introduction. And Gavi is right, though. I do have a passion for ECT. I've been working with ECT a long time in my career. I started in 1978 when ECT was very different than it is today. But one thing I can say that remained the same is that ECT works. Okay, so even though it was a harsher treatment at that time and kind of played into part of the stigma, it was always effective. So I'm going to talk a little bit about some of the fact and fiction that makes people feel a little bit afraid when they hear the word electroconvulsive therapy. So one of the things is ECT is only for depression. And that is fiction. It's most commonly used for severe depression, but can be used for mania, schizophrenia, especially early onset schizophrenia and catatonia and schizoaffective disorder. We have seen with the schizophrenia and schizoaffective disorder, we're not looking for a full recovery. What we're looking for is getting the patient back to baseline. Next, it is dangerous. That's another fact or fiction. So another fiction. The procedure is performed after a thorough medical workup and under medical supervision. Patients are given general anesthesia and a muscle relaxer to ensure that the seizure is mild. Many students that come through and observe ECT, the expectation of what they think they're going to see and what they actually see is very surprising. Okay, it can chip and break bones, chip teeth and break bones. That's another thing that, common question that people ask us when they're talking about ECT. Again, fiction, because of the muscle relaxants that are used and because we use a bite block in the patient's mouth to prevent them from chipping teeth, we don't have any injuries in ECT. We're here 6 years, 0 injury. It can cause memory loss. Okay, that's people's biggest fear about ECT, and that is a fact. So one of the most common side effects of ECT is memory loss. Memory loss usually covers events that took place right before ECT. And for most people, it doesn't last long. In my experience, I see that people, when they wake up, have a little difficulty recalling. And, I always remind the patients, you've just had anesthesia, you've just had a seizure. So difficulty in recalling is not that bad. We use unilateral ECT, which greatly reduces the risk of memory loss. Whenever you see ECT in a movie or anything like that, you're always seeing the paddles put on two sides of the, both temples. Most of the time now we use unilateral ECT. So it's one thing is placed on the top of the head and one on the right temple, and that kind of helps with the reduction of memory loss. Used to punish patients. So One Flew Over the Cuckoo's Nest, that was something that was used to punish the patients, and obviously that is fiction. It has a bad reputation in the past because it was used to tame unruly patient. It might have been followed back in the 50s and 60s, but absolutely not right now. And also one of the biggest fallacies is that ECT is a last resort. Many experts feel that it could be used as a first line of defense in some situations. It's one of the safest and most rapid treatments for severe depression. If a patient is highly suicidal, you may want to not wait for medications to take effect. You may want to order ECT. Also, sometimes in our elderly population, you may want to order ECT instead of adding another medication on a patient that may have a profile of many medical meds. So we have treated patients from 18 years old. Our oldest patient was 88 years old that was safely treated with ECT. So some fast facts: the American Psychiatric Association has established clear guidelines for ECT use. It's a safe treatment for pregnant women, adolescents, and elderly individuals. It's so safe that it is used in all 3 trimesters of pregnancy. Many patients, pregnant women may have bipolar disorder, has to stop the meds. If patient decompensates, ECT is a safe alternative. Approximately 100,000 persons annually receive ECT in the United States. 70% of them are women. It can be used to bring people out of catatonia, people that are awake but unresponsive to surroundings. I'm going to take a brief minute to tell a story about a patient that was catatonic, 22-year-old patient, catatonia, had to go to court to be court-ordered for ECT. It's something that his mother was very open to. She went to court, she agreed with the ECT. Patient hadn't been eating, hadn't been taking care of himself. One ECT treatment, and the patient was asking for McDonald's breakfast. Mom started crying because he hadn't been eating at all, and he continued to progress. He's currently a volunteer firefighter up in Ocala and doing really well. ECT is covered by most insurance companies, and the overall symptom remission rate for ECT is between 60 and 90%. And our outcome studies over the past 6 years have consistently been anywhere from 78 to 83% remission of symptoms. ECT is done under anesthesia by an especially trained physician. It can also help some medical conditions such as neuroleptic malignant syndrome, essential tremors, delirium, chronic pain syndrome, and Parkinson's disease. And we have seen some remarkable remission of Parkinson's symptoms in our patients. And there is no reliable evidence of any long-term harmful effects of ECT. Why is it so controversial? The film One Flew Over the Cuckoo's Nest did for ECT what Jaws did for sharks and the beach. The depiction of the treatment in the film is completely over the top, with the patient being held down, writhing in pain as he is electrocuted against his will. In cinematic ECT, the doctor is always an evil psychiatrist. It's being used as a form of torture. There's always foreboding music playing in the background if you see ECT used in a film. You have a resistant victim without mental illness and patient strapped to a gurney. The victim is conscious during the procedure. No muscle relaxant is given, patient's in pain, and there's repeated shocks with increasing voltage. The reality is that the doctors are pretty normal. ECT is being used as a form of therapy, not punishment. The only noises that you hear is an EKG monitor, and we always have soft music playing in the background. One of the things we do for our patients to reduce anxiety, we always ask them, what would you like to hear? And we usually put their favorite music on in the background before they go to sleep. Every patient is given anesthesia, a muscle relaxant. The procedure is not painful. One shock is given at a minimal dose required to cause the seizure, and it's given under carefully controlled conditions with very little risk. So in 1938, how did ECT come about? In 1938, Italian scientists Serletti and Bini used electricity to treat a catatonic patient by inducing a seizure. In 1940, ECT was introduced to the United States and became a widely used treatment for numerous psychiatric disorders. We have to remember that modern psychopharmacology didn't begin until the discovery of lithium in 1945, the first MAOI in 1957, thorazine in 1952, and the first tricyclic antidepressant in 1959. And then benzodiazepine and Librium followed in 1960. So ECT was one of the main forms of treatment. How it came about was a patient in an asylum. There was not a lot of meds, so a lot of patients ended up in long-term facilities that had mental illness. And a patient in an asylum that had schizophrenia with a lot of negative symptoms developed a seizure disorder, and his negative symptoms started to improve. And that's why they started to explore, how can we mimic this? Since ECT was developed over 70 years ago, it has been proven to be consistently effective in the treatment of patients with an affective disorder. It's effective in more than 80% of patients with treatment-resistant depression, and it's more effective than antidepressant pharmacotherapy. Leading researchers say that the modern version of ECT, far from outmoded, is the most effective therapy available treatment for treatment-resistant depression and bipolar disorder, even sometimes when deployed early enough in schizophrenia. Right now, I'm going to turn this part of the presentation over to Dr. Gaines.
Hello, everybody, and thanks for having me. So, in continuing, the mechanism of action of neurotransmitter theory, so the idea being that ECT stimulates a seizure. So that's actually the science behind the ECT itself. Memory loss is caused by the electrical conduction through the hippocampal structures that gives you the short-term memory loss. But what it does do in response is it stimulates the prefrontal cortex and amygdala with norepinephrine, dopamine, and serotonin in surging doses that you cannot approximate with medication. It's somewhere around 1,000 times the dose of an SSRI plus Wellbutrin. So we end up getting a significant surge in those areas, which helps significantly with depression. So it was known for a long time that seizures were helpful for that. The ability to use electricity to develop the seizure activity is how we see the mechanism of action work. So I guess the best way to put it is a much more potent dose of medicines that we are otherwise using to cause similar neurotransmitter reactions. Although because it also does work at the amygdala, it actually, even though you have short-term memory loss, it can improve executive functioning because you're getting, whereas you otherwise have shrinkage in depression in the hypothalamus and areas of the amygdala associated with fear, you'll have reversal of those effects that you don't typically see as promptly with medicine. So that's the neurotransmitter theory on how ECT actually works. I guess next slide, please. If I have to hit next slide, okay. Menu of neurotransmitters, right? So these are all neurotransmitters that are active in our brains. The ones that are of the largest importance in ECT are going to be serotonin, dopamine, and norepinephrine. There is also stimulation of GABA to help cut back on the seizure activity, but it's the increased production and redirection of dopamine, serotonin, norepinephrine to the prefrontal cortex and the amygdala that does generate the overall reaction. GABA is effective because it helps turn down the seizure, and it actually, the quicker that somebody's brain can shut off the seizure shows that it is in fact responding to the seizure activity. And again, the seizure activity causing the cascade of neurotransmitters. Endorphins are also released anytime there's any sensation of pain, as well as adrenaline, but those aren't specifically relevant to the improvement of depression or psychosis. Next slide, please. So, right, exactly. So what happens with anyone who has seizures is the brain actually tries to respond to stop seizures. The neurotransmitter reaction to the seizure produces the therapeutic effect that you actually see. So to say that it teaches the brain is like you're imagining an instructor standing over it, giving it lessons. It's a natural response to seizures for brains to try to fight to stop seizures. People that have seizure disorders have a seizure focus that is constantly stimulating. There is a robust response to try to stop it, but a lot of people that have an in-place seizure focus will need anti-epileptics to raise the seizure threshold and or combat the seizure that they're having. So yes, it is natural for a brain to respond to induction of seizures by trying to stop it on its own. When we do ECT, it's very common that we'll have to increase the electrical impulse and or add caffeine to help attenuate the seizures because there is some resistance to the seizures over time. And in fact, we can tell people are getting better when we see the length of seizure requiring larger and larger doses of electricity to obtain the same seizure length. It shows that their brain is resisting the seizures and would also have a predictable neurochemical cascade that helps treat depression. Next slide, please. So the overall workup. The only contraindication to ECT is a brain mass causing compression or an active brain bleed. It's otherwise extraordinarily safe. It's safe in pregnancy. The anesthesia in the ECT is safer in pregnancy than most of the medicines that we would otherwise use for psychosis or depression, just to give you an idea. But what does it do? Because people are going under anesthesia, you want to make sure people are safe for that. So what we've agreed on as a consensus is to check some basic labs, a chest x-ray. A CT scan for everybody is not typical. Again, you want to rule out a mass effect. If somebody has a brain tumor, that's going to need to be treated. And in theory, because there is an increase in intracranial pressure when you immediately stimulate a seizure, that could cause, in theory, brain herniation. So you wouldn't want that. Somebody has an active brain bleed, that needs attention. You don't want to exacerbate that either. Otherwise, typically we'll do a physical exam. You do want a baseline cognitive assessment, but we're doing that inherently in determining that somebody needs ECT in the first place. You always have to have consent. People need to know how the treatment works, especially the risk of memory loss that is very high with this. EKGs as a baseline. But again, to keep in mind, the only real medical risk would be if somebody had a mass lesion that is causing brain herniation or could, or an active brain bleed. Otherwise, there isn't a condition that we can't do it in. If somebody had a cardiac risk factor, changing the anesthetic agent to propofol puts them at lower risk. So we can even do it in that circumstance. And oftentimes we'll do ECT for people that can't tolerate really any side effects of medication because ECT is actually better tolerated. The memory loss, again, is a problem. But as far as like being able to successfully treat depression without bad outcomes, we see a lot of good outcomes from ECT. The anesthesia workup is necessary because before you're going to put anybody under anesthesia, you want to make sure that they're safe enough for even that. Okay, next slide, please. Okay, so the FDA has 6 cleared indications for use of ECT, as you see above. Its main benefit is in depression, but if you look at what it does with the neurotransmitter cascade that we discussed, it actually treats neurovegetative symptoms. We see that in schizophrenia. We see an inability to function due to racing thoughts in psychosis and mania. We see it in severe depression, or catatonia would be the most extreme example of psychomotor retardation that, well, between schizophrenia, depression, or mania, if you see psychomotor retardation or catatonia and neurovegetative symptoms, those are all symptoms that respond very well to ECT. So its original and most common use is in severe depression. And if we know most commonly, negative symptoms of schizophrenia, as well as psychomotor retardation and neurovegetative symptoms in depression are the most difficult to treat and reverse. Catatonia, again, would be at the largest magnitude of negative symptoms. And we see ECT help in all of those circumstances. It does treat mania. It does absolutely respond well for catatonia. It treats positive symptoms of schizophrenia, but not really any better than medications would for the positive symptoms. It's the negative symptoms that seem to respond better to ECT than they do to medicines. But again, if you have somebody who's pregnant or isn't responding well to medicines, ECT is safe and effective. But if you imagine catatonia being the most extreme end of schizophrenia or depression, then you could understand why ECT would work in all of these circumstances. And I guess it wasn't listed, but the FDA approval is for 18 years and above. We have been able to do it in adolescents as young as 14. In my career, 3 times, one 14, 2 16-year-olds with severe trauma, depression, had catatonic symptoms, and had been failing medications. It's obviously need approval of parents and approval of the court before you can do that off-label intervention, and it would be extremely rare that you would ever have to. But it's not FDA approved at that age. But that would be one example of an off-label time to use it for depression if somebody's 16 and with the same symptoms of it. But it is important to note that the FDA approval is what's listed above, but including 18 years old. All right, next slide, please. So, right, the primary use of ECT is as an antidepressant. If they're failing medicines, this is our most effective intervention for depression. The fact that you have to put somebody through anesthesia, the fact that it is going to, maybe it won't, but let's assume it's going to impact memory in the overwhelming majority of cases. This is why it's not used first. But that's really what it's for. When we say rapid, antidepressants SSRIs take a month to start working. Some people feel better after one treatment. The recommended amount of time to notice an improvement is 4 treatments. The typical series of 12, we use 4 as a benchmark as to whether or not people are actually having improvement. We say treatment resistance. I guess the idea being, if ECT is our best antidepressant, you're going to go to it to treat depression when all other interventions for depression have either failed or won't be tolerated. So we say intolerance or adverse effects, which would also mean that they're treatment resistant and it's not working. If they're deteriorating rapidly, ECT will work faster than any other intervention for depression, which is always true, but still have to weigh that against the risk of anesthesia, as well as the risk of memory loss. But if somebody is deteriorating, if they're catatonic and severely underweight, if medicines haven't been working, or quite frankly, we don't have a month to even wait to give it a chance because they're in such bad shape, then it is appropriate to use ECT right away. All right, next slide, please. Thank you. Okay, so again, indications. Major depression, if you imagine the psychomotor retardation, neurovegetative symptoms as the main target for ECT, then all of its indications would make sense. It would be for depression, catatonia. It does help with positive symptoms of psychosis, but so do antipsychotics. If they can't tolerate antipsychotics, then ECT makes sense for those, but it would have more impact. It would have a differential impact on the negative symptoms that you don't always see coming from medications. It would help also with postpartum depression. You can treat pregnant women safely with ECT. Neuroleptic malignant syndrome, if they had, this would fall under either poor response or inability to tolerate medications. Neuroleptic malignant syndrome, I would argue, is a poor response to medication. So if they're not tolerating medications, ECT, if we look at it again, is our most effective intervention for depression, would be appropriate in these circumstances. It does help treat mania as well. Perfectly safe to use in mania and very effective. Next slide, please. Okay, so thank you so much, and we'll go back to Elodia for more.
Thank you, Dr. Gaines. So, Doctor touched on the contraindications to ECT. There are no absolute contraindications to ECT, but there are some things that we have to be aware of. If cardiovascular-wise, if a patient had a recent MI or complaining of severe angina or aneurysm of a major vessel. So if any of these issues come up during a workup, not only do we get medical clearance, we get medical clearance from the specialist doctors, whether they think that it's safe enough for a patient to undergo ECT and to have anesthesia 3 times a week. Also, central nervous system, you're going to worry about a brain tumor or aneurysm, a recent stroke, or if the patient has a cochlear implant. So you don't want to cause any kind of seizure activity if the patient has these diagnoses. Glaucoma and retinal detachment are the last 2. The risks and side effects of ECT. So impaired cognition is the biggest thing that people worried about. Anytime we're working up a patient, oftentimes you may have, I always invite family member to come when we're doing the workup to watch the video, to get the education and to get the buy-in as well, because oftentimes it's the family members that have these concerns. Patient is depressed, their med's not working, they're kind of putting up their hands and saying, okay, I'll try ECT, and the families are most worried about this impaired cognition. And that does happen. There are periods of confusion immediately after ECT. Sometimes they wake up and they're not quite sure. The biggest thing they say is, when am I getting my treatment? They don't remember that they had treatment. And we have to convince them that it's okay to have a cup of coffee, you're done with your treatment. And that could generally last a few minutes to several hours. I will tell you that the majority of the time, patients leave ECT with their memory back. They're not confused when they're, we recover them a little longer if they're confused. Sometimes they'll come back and tell us that on the ride home, they may have forgotten something and, like speaking to somebody on the phone or something like that. But it comes back to them later in the day. There may be short-term or long-term and can be permanent in very rare cases. So in the 6 years that I've been doing this, we haven't seen anybody that had permanent loss, but we did see somebody who was a social worker by, her career was a social worker. She'd been out of work for 3 years due to her depression. She had young children who her husband was basically raising because she couldn't do anything. She was practically bedridden with her depression and only left the house to go to doctor's appointments. She suffered, we did bilateral ECT on her because she was not responding to the unilateral ECT. She had a memory loss issue, which lasted her about 3 or 4 weeks. So we were all feeling anxious about that because her memory was bad. She was not anxious about it because for the first time in 3 years, she went on a summer family vacation with her family and children. So she thought that was an okay trade-off. And then little by little, her memory started coming back. Again, she was a really good sport about it because she would joke that she could watch movies again for the first time, that she had seen already. One of the things we didn't mention, I'm going to go back to the previous slide for a second. The risks and side effects, well, the risks and side effects are high with the medications as well. So being in Orlando, we see a lot of patients that are here on vacation, and they end up in the hospital because they didn't want to take their meds, their psychiatric meds during vacation because of the side effects, okay? Because of one of the main side effects they talk about is the lack of sexual drive that the medications cause them. And they're on vacation, they're with their loved one, and that's something that they don't want to deal with. And then you get the stimulation of all the parks, and patient starts to decompensate because they haven't been on their meds, and they end up here in the hospital. So yes, there are some risks and side effects of ECT, but sometimes we have much greater risks with the medications, and we see that a lot. And some of our patients that opt for ECT is because of the severe side effects that they suffer from their medications. So most patients continue on medications after ECT, maybe a less meds or a lower dose, but they have to continue on meds. And some patients, we have a handful of patients that do really well on ECT and they stay off their meds because the meds always cause such severe side effects for them. some of the physical side effects right after ECT, some patients get nausea from the anesthesia, and we're able to give them a medication right in the IV. Once it happens, we try to not have that happen again. We give them some Zofran in the IV, and the patients are able to not have that side effect any longer. Muscle pain, sometimes patients complain, even though we're giving them a muscle relaxant and we're not seeing the full grand mal seizure. Physically, we're seeing it only on the EEG monitor. They have some muscle aches after the ECT, particularly in their jaws and sometimes in the big muscle groups like in the thighs or upper arms. Headache, again, could be from the seizure or anesthesia. And what we'll do at that point, we give the patient Toradol in the IV to combat that. And then some patients have fatigue and, often maybe need a nap in the afternoon after ECT. Dr. Gaines touched on the subject of the caffeine, so I'll just talk about that for a moment. Sometimes if a patient is not having the sustained seizure that we would like to see, the therapeutic seizure that we'd like to see, we do add caffeine to the IV, which sometimes can cause some GI upset, but caffeine is a proconvulsant, and we use that. And then sometimes what we also use and find very, very effective, we may add ketamine to the IV. So patients, you check in and on that treatment number 4, patient's not doing that well, maybe you add caffeine to the IV, and then you're at treatment number 6 and you're still seeing this patient not responding to ECT. At that point, we'll have a discussion with the doctors and the patient and decide to add ketamine to the IV. Ketamine is proconvulsant and antidepressant, so it's helpful in the treatment. And then we often see a big turnaround in the patient once we do that. And then we'll continue to use the ketamine throughout the rest of the treatment. And the cognitive side effect of ECT, one thing that I tell the patients that I have found to be very effective is to almost exercise the brain. It's almost like an exercise. So I tell patients, if you like doing puzzles, if you like coloring, doing the color by number, something that causes you to do a lot of concentration, that has been helpful with the memory loss. Even playing card games on the computer has been helpful. Despite the stigma of ECT, ECT is still practiced fairly commonly to this day. It's a much safer than before due to the precision in administering the current offered by modern day technology, which minimizes the side effects. And notwithstanding the controversy, it has the highest success rate in the treatment of major depression. And we talked about second line indications. We had a patient who had Parkinson's disease. His depression was related to his Parkinson's disease. So he didn't develop depression until much later in life when he developed Parkinson's. Well, when we started doing treatment with him, it was the first time we ever saw this, and it was quite remarkable. His Parkinson's symptoms started to get better and better. He had less and less of a tremor. Well, that was helping with his depression because he was able to do things again. At this point, he told us that he used to be a professional bodybuilder, and he brought in a book and showed us pictures from when he was a professional bodybuilder at a younger age. And by the time he finished ECT, he was back to the gym 3 times a week. And he was an older man. He was 77 years old. But he went back to the gym and started doing things because he was able to. He didn't have the tremor any longer, and his depression was lifted. So that's just one of the success stories. And I'll talk a little bit more about some other patients shortly. But at this point, I wanted to put a patient testimonial up at this point. It was from one of our patients. Her name was Michelle Griffiths. I'm going to read the note for you and talk about her just a bit. I was a patient at CFBH Hospital. I was in a very dark place with my depression. I had been to several mental health facilities for treatment, like nobody cared about helping me. I was suffering and needed help badly. My daughter took me to the Central Florida Behavioral Hospital after no help at the other places. I love the staff. I was on Breezeway for a while. I was not getting better. I was not in a good place mentally. I was offered ECT by the doctors. I went 3 times a week at first. Nothing seemed to be helping. The more treatments I got, the better I feel. The staff at ECT were my family and understanding where I was in all my crises. I eventually was successful with my treatments and finally showing improvement. I thank God for my extended family in ECT. I now have my life back and understand where I was mentally. God bless each and every one of you. Love, Michelle. This picture, The Best Is Yet to Come, that's up on the screen right now, was given to us by Michelle. And she has decorated our unit with other pictures that she colors for us. Right now, I'm going to turn it back to Dr. Gaines to talk about one of his patients as well.
Hello, thank you. So yes, with Carole, her story was just, it was really touching to see and to see the turnaround in her. And we have so many stories like this. It's just, it's rare that you get somebody though that we were able to work with for such a long period of time. This is giving a background on Carole and her education, just to show you that depression doesn't discriminate. It can get anybody. With Carole though, by the time we met her, she was so stubborn about doing it. She was refusing to do it. She was originally not willing to take medications. And then when we saw her turn around, it was just so rewarding. But if you look, she had a Bachelor of Arts in Education from FAU in 1982, a Master's of Education from FAU in 1988. She had worked 30 years for the Broward School Board, retired in 2016. One of her life joys was to work in Alaska. She did volunteer work, creating children's programs. And in 2017, she was actually working for Princess Cruise Lines doing tours of Alaska. And I know she was actually planning to do that this summer, but I know that didn't work out, but she stayed in good spirits. There's a world traveler, just a very worldly, classy woman with all the motivation in the world to be well, and depression was with her nonetheless. No matter what medicine she was taking, no matter how much therapy she had, she said she wore the same pair of sweatpants and t-shirt without showering for over a month. And this is somebody that was very well put together, that prided herself, had education, had friends, had family, still had them, but stopped engaging with them. Before we were in quarantine, she was living like she was in quarantine. She stayed in her house, I think, for over a year and a half before she finally came in. And even then, it took a few hospitalizations to convince her that she would benefit from ECT. Next slide, please. Is there? Okay. Hello, please, next slide. Thank you. So she says that she started to have depression that was obvious to her in 2018, specifically anhedonia, and as we're talking about the neurovegetative symptoms, the psychomotor retardation. She had a lot of that, stopped taking care of herself, and just started retreating in what she was willing to do. She was Baker acted 6 times due to self-neglect. She had lost somewhere over 80 pounds by the time she had come in. She had 20 different trials of medication, and she was compliant with it. After much argument and effort, she finally agreed to start doing ECT in last year, September of 2019. Next slide, please. So she's a great story because she didn't have memory loss. We saw a complete reversal of her symptoms. At the last event that we had, we were still all allowed to be together, and she was there presenting her own story herself. And she just said she felt like she was herself again. She felt motivated to go back to working in Alaska and doing volunteer work, and she had a smile, and she didn't have any memory loss. And since the psychiatric medicines weren't helpful before, we were trying to use those at the same time, but we didn't need them. She had had a full course. She had maintenance, and still a year later is still doing well. It was truly remarkable, and it's not all the time that you would see such a contrast before and after. It usually does help most people significantly, but just to see how much was stripped away from her over the years, the failure of medicine, the tolerability of the procedure, and then the life that she was able to go back to just because we were able to treat her depression really does help highlight how important ECT is as a tool and a mechanism to treat depression. Carole, by the way, is the one on the right. I know they both look healthy right now. That's Jillian. She's our chief nursing officer who worked very closely with Carole and stays in touch with her regularly. Next slide, please.
Dr. Gaines, I have some questions that popped up for you regarding the last two slides. The first question was, what was the depression trigger for Carole?
Fair question. So we weren't able to get from her a trigger. A lot of times there's always something that pushes it over, which is, if we're going to call it a trigger, that's usually fair. You could have people that are doing perfectly well and have a lot happen to them. Their exhaustion can develop it. In her case, it seems that the depression really took root right after she had finished that summer in Alaska. She had already retired and didn't have much to fill her time. But she said she was noticing it even while she was working. It just became unavoidable when she stopped working, when she stopped having a reason to get out of bed. She just never did. And then didn't shower, and then didn't socialize, and then, any behaviors, even though she was losing weight, and then thought, the only escape was going to be for her to die. So in her specific case, it looks like she had some, would otherwise call subclinical, because she had many years of habit that were in place. For her, it looks like retirement was, we're going to call it a trigger, was hers.
Okay, and the second question, doctor, is from Kenneth K. Regarding the precision of administering electric currents, is ECT able to target specific regions of the brain? And if so, how specific? And which regions assist with this disorder or symptoms?
Excellent question. So we're able to place leads precisely, but we place them on the temporal lobes because that's the largest area for seizure focus. So the electricity is not the therapy. The seizure is the therapy. And actually, even in today's time at Harvard University, they still use hypoglycemic shock to create seizures with good success. It's very difficult to do. It's very risky. You don't run a risk of memory loss. It's actually the seizure that's induced that's therapeutic. You're able to target the temporal lobes, but in order to get any kind of an electrical current, just like if you imagine you're trying to jumpstart a car, you have to have a positive and a negative to cause a flow of electrical current from one pole to another. So where do you place the leads? Unilateral ECT uses the top of the head as a ground. It's not therapeutic to stimulate the top of somebody's skull, but if you place one lead over their right temporal lobe, you're stimulating that temporal lobe. The electrical signal would then move from the right temporal lobe across the corpus callosum to the left, and you could get a full brain seizure even though you're only stimulating one side. The reason that's associated with less memory loss is you would imagine there's less electrical current passing through the hypothalamus. I'm sorry, the hippocampus. You're having less electrical current pass through the hippocampus, so you're having less memory loss from that. There's also bifrontal, where you can stimulate a seizure by placing it on the frontal lobes. That's used often in elderly patients. It's just when compared to bitemporal, there does not seem to be much significant decrease in memory loss and no larger differential in therapeutic improvement. There's also what they call is abbreviated LART, L-A-R-T, which stands for left anterior, right temporal. But imagine instead of unilateral, that you, instead of the second lead for a current being placed on the top of somebody's head, it's placed over their left frontal region, so that it really does function as a hybrid in the efficacy between unilateral and bilateral, and can be done throughout the entire process too, and is effective. As far as how precise can we be with the electricity, if you're familiar at all with TMS, that uses magnetic energy to help stimulate, which can be very precise in its location. The electrical current with ECT is not as precise because it's going from one pole to the other. So you're actually looking at a line, not a specific point that you're targeting. TMS targets a specific point. ECT is a line. So if you think of it that way, it can only be as exact. It will go from one pole to the other. So depending on where you place your leads is where the electrical current is going to flow. The temporal lobe is the most common location for naturally occurring seizures. Tumors that affect the temporal lobe are common to cause seizures. So electrical stimulation of the temporal lobe is effective in causing seizures. So I hope that helps. I hope that helps answer the question.
Okay, I'm going to answer two questions from Erica G right now. What is the average number of treatments for each condition? And what factors would be contributing to lack of responsiveness? And when you say lack of responsiveness, do you mean the seizure in that moment or post-ECT, it hasn't made a difference? So the average number of treatments we do is anywhere between 9 and 12 treatments during the acute phase of treatment. There's two phases of treatment, acute and maintenance. So based on each individual patient and their response, and by response I mean, are they getting better? Are their symptoms going into remission? Based on that, say we do the average of 12 treatments, and we do 3 times a week, Monday, Wednesday, Friday, for 4 weeks. At that point, we start to put the patient on what's called maintenance ECT, and we start to wean the patient off of 3 times a week. We go down to once a week. What we do at that point is every time the patient comes back, we check in. We do a check in on their symptoms and see how they're doing, and then we decide at that point, can we spread the treatments any further apart? So we may start at once a week, do that for 2 weeks, and then the patient's responding, they feel well, they don't have many dips during that week period. We'll switch them then to 10 days or 2 weeks apart. And eventually the goal is to put them on monthly ECT. When they're on monthly ECT, many patients continue doing monthly ECT for quite a while, but sometimes the patients decide, okay, I feel great, I'm not gonna continue this. And we always tell them, if your symptoms come back, just call us and we'll get you back in to get you back on track. We have a handful of patients, I'm gonna say maybe 5 patients right now that do ECT every 2 to 3 months, and they stay well. So that's the number of treatments. And what I meant by the ECT not making a difference, I meant in their symptoms. The second question that Erica asked is about treating veterans. And I'm very proud to say that we have a large population of veterans that we treat here. The veterans with the place of choice in our area that the Veterans Administration sends the patients to, and we do a full workup on the patient, and at any given time we have a large number of veterans. It's very effective on their symptoms. We've had great success with them. Oftentimes they feel well enough to try to start to participate in therapy because there may be many areas. That's one good thing about ECT. Patients may be so depressed they're unable to participate in their therapy. So they go to therapy or they don't show up, or once they start getting better, we start to initiate with the patient. Now's the time to start to get back into therapy, whether it be PHP, IOP, or outpatient therapists. And they maintain that throughout their whole maintenance period as well. Okay, just to talk about the referral process now. We put up on the screen the numbers to call at both Fort Lauderdale Behavioral Health Center and Central Florida Behavioral Health to call and get a referral. You can either call or fax the referral over, and we'll contact the patient directly and set up the appointment. A couple of good things about the referral process: we have no waiting list. If we get a call from somebody to evaluate a patient, we do all the outpatient evaluations on Tuesdays and Thursdays, the non-treatment days, and we're able to see them that same week that we get the phone call. And usually from that first referral, to go through the whole process and get medical clearance and first opinion and insurance authorization usually takes about a week. So within a week, we're usually able to start the ECT. And again, here's our contact numbers and email for getting a referral in. Oftentimes, we may get a call from the therapist or the doctor directly, get a little information from us, and then they give us the patient's phone number, or they give the patient our phone number and we set up the appointment. To be a freestanding psychiatric facility is a really nice place for the patient to get ECT. They don't have to maneuver through a very big hospital. We have parking right outside the building. It makes the patients feel comfortable. During these unusual times with COVID, unfortunately, we don't have families come in. We just have the patients come in. But we go out to the car to greet the family. When we bring the patient back out, we're able to answer any questions for the family at that point. We do allow the family to come in during the workup process because we really encourage families to watch the video, take a little tour of our unit, to develop some kind of comfort level for the patients to come back.
Okay, Elodia, thank you so very much. This is Davi Vernon taking the microphone back over. Dr. Gaines and Elodia, thank you. I do have a couple of questions actually that came to my phone. Jessica H. does have one question for you, Elodia, and the question is, what actually happens at the initial ECT consultation? How do you work with the families to alleviate their concerns?
Okay, so when the family, patient and family comes for that initial visit, it's a very relaxed, we try to make it a very relaxed atmosphere for them. We have them come in, give them something to eat or drink, and sit down and just kind of take a history from the patient. Oftentimes the family, really likes to participate in that because a depressed patient sometimes is not the best historian. They don't, feel like talking an awful lot. At that point, once we feel comfortable with each other, I put a video on and we watch a video that's about 25 minutes, and it really goes through the whole process of what's going to happen. After that, sit down and talk with the patient and family again for any concerns that this video may have brought up. Sometimes patients don't realize they're going to get general anesthesia. They're going to actually have a seizure. Sometimes patients come in with not a lot of information. So we sit down again, talk about that process, and at that point, I give the patient a prescription for blood work and EKG. And depending on their history, I might give them a prescription for, an X-ray as well. But oftentimes it's blood work and EKG. When we get the results back, which usually is within a day or two, we call the patient back in, and at that point they come and we have what we call our ECT outpatient clinic, and we have our medical team and our psychiatrists meet with the patient. They get a history and physical, medical clearance to begin ECT, and first opinion from the our psychiatrist. And then that's it. We submit that whole package to our utilization department, get insurance authorization, and then the patient's able to start ECT.
Thank you so much for that answer. I have another really good question here, actually, and this question is coming from Myra Barrero. The question is, at what pregnancy trimester can you start, or do you start ECT? It's a great question.
Okay, so it's safe in all 3 trimesters of pregnancy, but in our facility, because we're a freestanding psychiatric hospital without a medical emergency room, nursery, and so forth, we only do it during the 1st trimester here. They would, if they're in the 2nd or 3rd trimester, then we would refer a patient to a medical center, a hospital that does ECT. Because we don't have a nursery, it's not that ECT is going to cause anything, but if the patient was to go, in unexpected labor, we don't have the facilities to care for the baby.
One other good question. This is coming again from Erica G. Does this work for dual diagnosis patients with substance abuse? Is that something that we would consider looking at for a workup and eval?
Okay, consider looking up for a workup and eval is absolutely yes. But the nature of that dual diagnosis sometimes can be tricky. It depends on how motivated is this patient to continue treatment. So sometimes from our dual diagnosis unit, we get a referral and we do the ECT, and unfortunately, patient may relapse and not come back to follow up. We do random, if they do come back, we'll do random drug screens on the patient if there's any suspicion that the patient may be, have picked up and started using again. Could be dangerous with the anesthesia. So, we keep up with random drug screens. We've had some success stories. Those are the patients, unfortunately, that due to the recidivism of the diagnosis itself, sometimes the patients don't thoroughly complete ECT. So we're very careful with starting those patients.
I have another question. The questions continue to come in. So guys, if you have any questions, please don't be afraid to ask. This one's coming from Kimberly V. If a patient uses ECT and is able to get off of medications, would they possibly get occasional future treatments to address symptoms? And I think this actually kind of segues into another really good question that someone just texted me on my phone. And that question was, can you describe the difference between the initial ECT treatment and the maintenance treatments?
Okay, I'd be happy to take that question. So there is no difference between the acute and the maintenance. The treatment itself remains the same. So if the patient got better on bilateral ECT, we continue bilateral ECT for maintenance. If the patient got ketamine, then we're most likely going to use ketamine during the maintenance treatment as well. When the patient is not on any medications, because the patient doesn't want to start back on meds or something, we really encourage maintenance ECT at that point, because their condition is a chronic, it's a chronic condition like diabetes and heart disease. You need some kind of help. So we try to encourage those patients. But if they don't want to do maintenance ECT and their symptoms come back, we do what's called a rescue series. That's what we call it here, a rescue series. So a patient is doing well for a full year, and then they give us a call, symptoms are coming back. And this happens quite often. We do see patients after a year or so sometimes. And what we do is the rescue series, and at that point, we probably only have to do, based on how long they've been away, we do about 6 treatments instead of 12. Try to get the patient back on track where their symptoms are under control or in remission, and then we go into maintenance at that point. Sometimes those patients that come back for the second time decide that they're going to go ahead and continue with maintenance this time.
Thank you. Another really good question from Karen Lord. Is this appropriate for someone with a brain injury or a non-active brain bleed? Dr. Gaines, do you want to field this question?
Yes, absolutely. Yes, if they have depression or psychosis, it's going to help with dementia. It is not preferred treatment for aggressive behavior as a consequence of traumatic brain injury, but it does target depression regardless of the etiology.
Thank you. And finally, I think another question that everybody's asking here in Elodia, I'm sure you have a lot of experience with this regarding insurance, what they'll cover, what they won't cover, whether somebody can be inpatient or outpatient while they're doing ECT, or whether they can actually be in outpatient therapy at the same time and get covered as well. How does that all work?
Okay, I'd be happy to answer that. So with insurance, each insurance company, as we all are well aware of, can be a little bit different and may require different information from us. But our workup packet includes not only the medical and psychiatric opinions for ECT, but we do a MOCA, which is the Montreal Cognitive Assessment, to get a baseline of the patient's memory and cognition. We also do a depression inventory, the QIDS, and we also do a history of past medications and current medications, and that is part of the package that we send to the insurance company. Now, I'll tell you that probably 90% or higher of the time, that's enough information and they give us authorization for treatment. But sometimes they may require us to go back and get notes from their outpatient psychiatrist that maybe show more of a history than we're giving them. But that's on the rare occasion. As far as inpatient versus outpatient, if they meet inpatient criteria, then while I'm doing the workup, I will walk them up to our intake department and have them get admitted for initial inpatient treatments. But a lot of our patients start directly from outpatient, and insurance does cover that as well. If they start inpatient, I'm going to say generally we do the first 3 or 4 inpatient, and then the patient's able to continue as an outpatient. One of the other things I didn't mention, but for anybody that's in our area, we do provide transportation for our patients. So we don't let transportation getting here, be a roadblock for the patient, and we're able to pick them up within 30 miles of our facility. Sometimes they may have.
Behavioral Health Center is also able to provide transportation. We do have a contract, and we are able to transport with up to a 40-mile radius of our hospital.
And I'm sure you as well find that as a big hurdle that we take care of for the patient, because sometimes they just can't get that ride here. Early in the morning, we start at 6 a.m. Patients have to be here early, so as long as we know they have someone at home to receive them when they go back, because they did have a treatment and anesthesia, then we provide transportation for the patient. I hope that answered the whole question.
Thank you very much, Elodia. Let's see what else we have here. I think one other question from Arlene Van Ost. Do patients go off of psychotropic meds while receiving ECT?
From our end, I'm going to say no, the patients don't have to go off the psychotropic meds. Some of the meds that the patient cannot take during ECT, the day before ECT, if you have any of the anti-anxiety medicines like, Ativan and Xanax and so forth, we stop that medication at 4 o'clock the day before treatment because it can be anticonvulsant and the patient would have difficulty having a seizure. They don't get their sleeping pill the night before treatment as well for the same reason. And sometimes, the mood stabilizers that are anticonvulsant meds like Depakote, for example, we don't take them off of that medication. We just monitor if it's a problem with the seizure, and then we'll talk with the ordering physician about maybe changing schedule of the medication.
Thank you. And another question from Lucille Thomas. I think this is a good question because somebody with the long-term experience that you have I can probably answer this well. And the question is, what's the average length of time can patients go or could go, I guess, potentially without their symptoms returning?
So just from experience, I'll just talk about the patients that we have. Patients stop coming to ECT, not having ECT at all. It's a guesstimate, but I would say that about a year is when we find that we're starting to hear from some patients that haven't had ECT in a while. But they report that they had a great remission of symptoms, maybe 8 months or so, and the last couple of months they were struggling about whether to come back and start ECT again, and then they do.
And this question here, this question is actually for Dr. Gaines. Very good question here. What are post-procedure risks of seizures?
So fair enough. Actually, the other way around, if you have a seizure disorder and you have status epilepticus, meaning non-ending seizures, ECT is one of our best interventions to help stop it. The GABA surge that comes along with the cascade of neurotransmitters actually helps prevent seizures. So if you're asking for risk, there's disorientation from the anesthesia, there's some motor disorientation from the ECT and the electricity. So after anesthesia, you wouldn't want somebody driving. In theory, the next day, they could still be slower in their reaction times, but you can test it before you have people leave. They're not at a higher risk of having seizures after ECT. They're at a lower risk of having seizures after ECT. That's why we have to use higher and higher charges to elicit the exact same response. Most of our post-treatment risk, other than memory loss, is going to come from the anesthesia. The muscle soreness doesn't come from the seizure. It comes from the succinylcholine that works first as a stimulatory agonist at voluntary muscle receptors and then as a blocker. So if you imagine if you did a muscle lift with every one of your voluntary muscles simultaneously and then relaxed, that's why people wake up sore if they're properly treated with succinylcholine. It's still better because they don't get thrashing movements that put them at risk of fractures like they used to have before succinylcholine. But the muscle soreness doesn't actually come from the electricity, actually comes from the succinylcholine. I guess I hope that answers the question. If the way that I was picking it up is, are people at more of a risk of seizures having been given a seizure? Actually, having been given a seizure, it helps prevent further seizures. And again, evidenced even more so by the fact that we have to either add caffeine or increase charges to get another seizure in the future treatment. And it is still our best intervention for status epilepticus is to give somebody a bitemporal ECT. So that would break the seizure that they came in with.
Thank you. Thank you. Well, another question that I think Dr. Gaines is probably a good question for you. This comes from Arlene Van Ost. The question is, if ECT has a 90% success rate, why are antidepressant medications always the first line of treatment? And I think that's a really good question considering the topic of what we're discussing today, which is, breaking the stigma for ECT and all that surrounds it.
Okay, so that's a fantastic question. And I've even in my own clinical practice, I asked the same question. And I guess if I was allowed to, I would use it much more early, much more often. The stigma is probably the best answer to it. The memory loss is problematic. So I don't want to make light of that. We do it because the outcome is still worth the risk of it. But I don't want to make light of the memory loss, which is very real. If you're at work, you're not going to be able to go back to work while you're doing it. Not because we're not letting you, it's because you're going to be forgetful at it and need time to recover from it. So that usually can throw a huge monkey wrench in people's lives. But if there wasn't the stigma surrounding it, and if you look at sexual side effects from medicine, weight gains from medicine, the amount of time for it to work or perhaps not work, it's a much stronger argument. Plus, since we're saving it as a last resort, you're always going to end up with people that have failed multiple. Look at the success rate from ECT and knowing that we're self-selecting individuals that are already at a lower risk to respond to treatment at all. So just imagine what it could do if you took somebody who otherwise wasn't treatment resistant but did it early. Those studies have never been done. The memory loss is a real concern. The fact that it has anesthesia is also a real concern. But I'd have to argue the stigma is still playing a large role in that. That being said, am I taking patients and saying, listen, don't mess with all the medicine, let's do ECT? Of course not. I'm following standard of practice, but it would take a head-to-head trial with early onset depression, comparing them for that to become shown to be effective hopefully you would have lower doses of electricity and therefore less memory loss, and be able to compare them side by side before it could become standard of care. But I guess the work hasn't been put in to test that it would be worthwhile to do up front. It makes sense conceptually, but I guess the answer is because it was viewed in such a negative light, it was only if everything else is failing us, which isn't really fair to the treatment. It makes more sense to be able to discuss all treatments, the pros as well as the cons to all of them, including medicine. But hopefully that answers it. That's why I think it's not first line or used more often.
Thank you. And while we're sitting here listening to that answer, Elodia, I think wanted to add one point.
Yeah, I want to absolutely agree with Doctor, because I hear from our outpatient referring physicians all the time that they've been wanting to refer this patient for ECT for a while. It takes them a while to build up that, trusting relationship with the patient, that they don't want to feel like, that the doctor is saying something that's so bizarre, because that's what a lot of patients feel when the subject of ECT is first brought up to them. I went in to do a presentation at a doctor's office, a psychiatrist's office, and the staff at the desk, when I told them who I was and what I was there for, said, "Oh my God, I thought that was illegal." This is somebody working in a psychiatrist's office. So if a patient hears that, the stigma that's attached to ECT, I think, is the biggest, deterrent in getting our patients the help that they need a little bit sooner.
So just to piggyback off that question, Dr. Gaines, when would somebody know, or I guess what would be the appropriate time for a person to go ahead and make a referral? What do they need to know? At what point do they make that referral?
So it'd be fair for them to be treated for depression. We try to look for 3 failed trials of an antidepressant, including an augmentation strategy with Wellbutrin and or with an atypical antipsychotic, again with at least 2 SS and 1 SNRI with Wellbutrin or with an atypical antipsychotic, Seroquel XR, Abilify, and or catatonia, pregnancy, and therefore feeling not comfortable to use either Haldol, Wellbutrin, or Benadryl that we have that are safe to use in pregnancy. So the patient's really declining despite using it. Give it 3 trials, because one of those trials would at least be an augmenting strategy, or a significant rapid decline. We don't have to have 3 failed trials to justify doing it. It's just what's turned into the standard of care. I guess I'd recommend it for somebody that's dropping very quickly because it's our quickest intervention. Anyone who's catatonic, anyone who's acutely psychotic that would probably be in a hospital and isn't responding to medicine. Or, like I was saying, if they're trying medicines, they've had 3 trials along with augmentation strategy, and either due to side effects or lack of efficacy or both, then refer for ECT, and it would make sense for us to do.
Excellent, thank you. Okay, I think I don't really see any further questions. So I think we'll kind of conclude over here. Someone asked the question about the link to the evaluation. Again, you're not going to have a link to the evaluation when this meeting ends or when you close Zoom. You're automatically going to be brought to the page where you actually do the evaluation on a Google form. Okay, so it's going to be done digitally, and that's how you're going to get your CMEs or your CEUs. Lydia talked a little bit about Central Florida Behavioral Hospital's way of making a referral. I wanted to just give the opportunity to Kimberly. Do you want to talk about for your facility for Fort Lauderdale? How what's the best way to make a referral? Who should they reach out to? Is it you, intake, or the program director?
Yes, so our Chief Nursing Officer, Jillian Wersman, her contact information is posted, but we also have a single point of entry, which is our admitting department, and we can make sure that somebody gets sent in the right direction if they call into our main number.
Awesome. Okay, well, I think if anybody has any further questions, they can, of course, email myself or Kimberly after the training. I'm going to follow up this presentation with an email that has the certificate of completion. I'm also going to add the link for the evaluation just in case for whatever reason you accidentally close out your browser. And I'm going to add some additional resources too on ECT. Additionally, again, this webinar is going to be available for those that want to watch it or share it with others on our resources section of our webpage. Kimberly will make it available as well. So please look for that within the next week or so. And lastly, I do want to also say everybody on this call, if you'll go ahead and like and follow the Fort Lauderdale Behavioral Health Center and Central Florida Behavioral Hospital's Facebook accounts, it'll keep you posted on all upcoming and future trainings like this one. So with that, I do want to end on one last point, and that was what someone hit on regarding the veterans. That's, and Elodia mentioned already how that's really, one of our most successful areas in terms of the demographic we reach and who we treat. We regularly go out to the VA over here in Orlando to do trainings to keep their staff current for their psychiatric unit. And I will say that myself and Kimberly, we both, our jobs is to go out into the community and to provide education on subjects such as this in our programming. So if anybody has, if anybody would actually like to have us come out in person on whether it's our ECT program or any other program that we do, which is of course on our website, feel free to reach out to us directly and we'll get in touch to coordinate and have our program directors come out and educate your staff. And with that, I'm gonna say thank you so much everybody for joining. Thank you, Dr. Gaines. Thank you, Elodia. Thank you, Kimberly. I hope everybody has an excellent rest of your week and a great rest of your day.